we come to abdominal vasculature. So we're going to view the vascular components of the abdomen, which include the abdominal aorta, the inferior vena cava, the portal venous system. And we're going to look at vascular abnormalities of these structures. So certain key terms: abdominal aortic aneurysm is enlargement of the diameter of the abdominal aorta to greater than 3 centimeters. So an aneurysm is any dilation of a blood vessel, whether focal or diffuse. Budd-Chiari syndrome, this is described as the occlusion of hepatic veins with possible coexisting occlusion of the inferior vena cava. An intimal flap is observation of the intimal layer of a vessel as a result of a dissection. So we can have a true aneurysm, which is the enlargement of a vessel that involves all 3 layers of the wall. And a Wilms tumor is the most common solid malignant pediatric abdominal mass. So we can move on to the anatomy and physiology of the abdominal aorta. So the aorta is the largest artery in the body, and the aorta originates at the left ventricle of the heart. The subdivision of the aorta within the chest is referred to as the thoracic. Once the aorta passes the aortic hiatus of the diaphragm, it is referred to as the abdominal aorta. The aorta is retroperitoneal in location, and it is positioned anterior to the spine, left of the midline. The walls of the aorta consist of 3 layers. The layers are known as the tunica intima, the tunica media, and the tunica externa. The innermost layer, closest to the flowing blood, is the tunica intima. There's a muscular layer, which is known as the tunica media, and the outermost layer is known as the tunica externa or tunica adventitia. The aorta supplies blood to abdominal organs, pelvis, and lower extremities. And it has quite a number of branches. So here we can see the 3 layers of the aorta: the tunica externa, the outer coat, which is composed mainly of collagen and elastic fibers; the smooth muscle layer, which is the tunica media, which is the middle coat; and the tunica intima, which is close to the lumen. And the tunica intima is composed of the endothelium, with some connective tissue, and an internal elastic membrane. So the celiac trunk, may be referred to as the celiac artery or the celiac axis, is the first main visceral branch of the abdominal aorta, and its branches supply blood to several vital abdominal organs. The celiac trunk arises from the anterior aspect of the abdominal aorta, between the crura of the diaphragm, and it branches into 3 arteries: the splenic artery, the common hepatic artery, and the left gastric artery. And here we are: the splenic artery, the common hepatic artery, and the left gastric artery is not shown, but it is one of the branches of the celiac trunk. Now, the common hepatic artery and the splenic artery are readily seen in transverse scan plane, and combined with the celiac trunk, they have a seagull or T-shaped appearance. Because of its small size, the left gastric artery is not typically seen with sonography. So flow within the celiac artery should be continuous and forward, whereas abnormal flow will be having elevated velocities. So you can see branches of the abdominal aorta. We have the first branch is the celiac trunk, branching up to the hepatic artery, splenic artery, and the left gastric artery. Then we have the right and left renal arteries. Then we have the superior mesenteric artery, the left and right gonadal arteries, and the left and right common iliacs. So normal flow patterns of the abdominal arteries. So the abdominal aorta suprarenally demonstrates a low resistance flow pattern, much like this, and infrarenally, this is below the kidney, demonstrates a high resistance flow. The celiac artery represents a low resistance flow, same with the common hepatic artery and the splenic artery. Now the common iliac artery has a high resistance flow, and the renal arteries have low resistance flow patterns. The celiac axis in the longitudinal plane, we can see the celiac artery, which you've seen branching from the anterior aorta, and it branches proximal to the superior mesenteric. And in the transverse plane, the celiac artery can be seen branching from the abdominal aorta into the common hepatic and splenic arteries. And so we had said the normal flow in the celiac artery is low resistance. As you can see, low resistance. The superior mesenteric artery is the second main branch of the abdominal aorta, and it typically originates along the anterior aspect, just distal to the original celiac trunk, and it supplies blood to the small intestine, some of the colon, and the pancreas. 30 to 90 minutes postprandial, the superior mesenteric artery will yield a low resistance waveform, and this can aid in the diagnosis of small bowel ischemia. In a fasting patient, the SMA will exhibit high resistance flow. Although 30 to 90 minutes postprandial, it will return to low resistance. So you can see high resistance waveform here. Normal high resistance pattern is demonstrated, so we can assume this is a patient who is fasting. Moving on, the renal arteries. The third main visceral branches are the paired renal arteries, and they arise just below the level of the SMA. And they originate from the left anterolateral aspect of the aorta and travel posteriorly to the renal vein. So as you can see, here's inferior vena cava, and the right renal artery crosses behind the inferior vena cava, and there you are. And the fourth branch is gonadal arteries, arise from the anterior surface of the abdominal aorta, and they can be either testicular or ovarian depending on the gender of the patient, and they are not generally imaged with sonography. The iliac arteries, the aorta bifurcates at or near the level of the umbilicus, and this marks the origin of the right and left common iliac arteries. Aortic bifurcation is seen here. You have your distal abdominal aorta, you have your right common iliac artery and your left common iliac arteries. Aneurysm. So any dilation of a blood vessel is referred to as an aneurysm. An aneurysm, in the case of the aorta, occurs when the diameter of the aorta exceeds 3 centimeters, and the most common shape is fusiform. Fusiform aneurysm is one that has a gradual enlargement. Aneurysms can also be saccular, which is described as a sudden dilatation of a vessel, and saccular aneurysms are often spherical and can be fairly large. Sonographically, the diameter of the abdominal aorta would measure greater than 3 centimeters, and we might see thrombus within the aortic lumen. A along with the thrombus, we might see calcifications producing acoustic shadowing. So here you can see a normal artery. This is a false aneurysm. The intimal lining is still intact. You can also call this a pseudoaneurysm. This is a true aneurysm. This is what we call a fusiform aneurysm. This is a saccular aneurysm. This is a dissecting aneurysm. So here we are, fusiform or saccular abdominal aortic aneurysm. Fusiform, saccular. So here you have a true lumen versus a false lumen. True lumen, false lumen. And if we have a false lumen between the calipers, exposes the clot. Aortic dissection. This occurs when there is separation of the layers of the wall of the aorta, and the intimal flap may be noted within the aortic lumen, such as that or that, and a transverse image of a dissecting aneurysm demonstrating the intimal flap. So you have it in longitudinal and you have it in transverse. And you can see narrowing of the aortic flow shows increasing speed in the Doppler. Aortic rupture has high mortality and morbidity, and aneurysms greater than 7 centimeters in diameter are more prone to rupture. Sonographically, we see abdominal aneurysms with an adjacent hematoma. Pseudoaneurysms. These are contained rupture of blood vessels, and it's most likely secondary to the disruption of one or more layers of the vessel's walls. Sonographically, a perivascular hematoma containing swelling blood, and that has a neck connecting it to the second vessel. The color Doppler would demonstrate turbulent flow within the mass. Tumor invasion of the IVC. The IVC is the largest vein in the body, and it is created by the union of the common iliac veins. Now the IVC has 3 layers, the tunica intima, tunica media, and tunica adventitia. It has a small amount of smooth muscle, and it travels superiorly through the abdomen. It is considered retroperitoneal and is also located anterior to the spine, and it is right lateral to the abdominal aorta. The IVC travels through the vena cava, foramen of the diaphragm, and ultimately terminates in the right atrium of the heart. It can be separated into 4 sections: the hepatic, pre-renal, renal, and post-renal IVC. Sonographically, the hepatic section of the IVC can be recognized as an anechoic tube in the sagittal plane, marking the posterior border and the caudate lobe of the liver. In the transverse plane, the pre-renal and renal IVC will be oval in shape and can be seen to the right of the abdominal aorta. The size of the IVC is variable, although its diameter should never exceed 2.5 centimeters. So the tumor invasion of the IVC is often associated with renal cell carcinoma, and the tumors occupy the renal vein initially, move into the IVC, and may advance into the heart. The main portal vein is created by the union of superior mesenteric splenic veins, and the confluence lies with the mid-abdomen. The normal flow pattern is hepatopetal and monophasic, and it should not exceed 13 millimeters in diameter. You can have abdominal collections between arteries and veins, and we refer to these as arteriovenous fistulas, and these may result from simultaneous punctures of the veins and arteries, or connection between a vein and artery. And we can note these on color Doppler.